all the sequences and show you, so that in case you are presented with other ones. So we don't do much with diffusion. Okay, we have them, but we don't do them. So this is T2. This is a T2, and then this is a T1. Okay, and then what is this important for you? If the breast is very dense, you are going to see structural thing here. See how well you see it on the T2. So always, T1. So on the T1, always look for the structural things, because when it's glandular tissue, you're going to see it like this, like that. And when there's a mass, you're going to see it very easily on the T1. So this is a clip in the mass. See that? Biopsy clip we put. So that's a biopsy clip. And then this, I'm going to bring the, so this is a pre-contrast. You take image before you give the contrast. So this is pre-contrast T1. And then this is the post, and then this is the same. This is now they've given contrast. This is post-contrast. So you subtract this image, and then you get these subtracted images on which you should do all your, except the lymph nodes. Don't look for the lymph nodes here. So on the T2, look for cysts, look for fibroadenomas. They have a typical thing. On the T1, look for the structural abnormalities. And on these ones, you always need to look for any enhancement, abnormal enhancement, segmental or whatever. These are the MIPS. So on the MIPS, you can really make out very beautifully. Look at that. That's the DCIS. Now you can correlate with the mammogram and MRI, and you see this finding is very important. This is the second mass. So this is the MIP, and this is the kinematics. So mixed kinematics, it demonstrates.
Okay, ma'am. Ma'am, the next question is, what is this blue and red color showing?
So this question is that we used to generate those SI curves. So then vendors, these vendors, they came up with software in which these images are called kinetics or kinematics, in which those you don't have to generate curves. Like you would put a ROI here. Before, how we used to interpret them, you would put like an ROI here, and then you would put like this, and then you would generate a curve, and then you would see is it type 1, 2, 3, because here you can't tell what it is like. And then you have to put up all the serial images. So you do you do dynamics. So you do 4 runs. So this is phase 1. This is phase 2. And then you can see that it's washing out. It has become less already, right? And this is phase 3. And then this is phase 4. So typically we do 4 phases. And then you want to know what is happening. So this is a mass. There's no question this is a mass, but are you always presented with masses? No. You have so many things in the breast. Some people have fibroadenoma, some people have fibrocystic changes, multiple things. So everything is not going to be this simple. If I didn't have the kinetics here, I wouldn't care. I'm going to say a mass. But there are many things you don't even know what they are. So then this helps, because this is going to tell us what is happening in it. How is it enhancing? Is it washing out? Is it not washing out? So this is the kinematics. It is a colored map of, you don't need to generate those SI curves to show washout, plateau and all that. So when it is blue, that is progressive enhancement. That is the type 1 curve in which it keeps enhancing, right? And then plateau is it enhances and then it levels out. That is the green one. That green one. And then this is washout, in which it takes rapid contrast and it washes out. Very highly suspicious for malignancy. So these are the 3 types of things you see on these images. These are the kinematics. I don't know if they're there in Pakistan or not, but even if they are, they can show you curves. So you need to know the curves. I'm sorry, I don't have those because we don't do those anymore, but these are what this color indicates. So if it is washing out, it is very suspicious for malignancy.
Okay, ma'am. The next question is how to differentiate between BI-RADS 4C and 5.
Okay, so it's not a very big difference. When something is looking highly suspicious to you, then you need to put it into 5. When there are lymph nodes, the first case we saw, there's that mass, ugly mass. It had pleomorphic microcalcifications. You can see enlarged lymph nodes. You can see they have microcalcifications. That is 5. If there's a single thing, which is speculated, and or it's even if it's well defined. I might have another case here. Okay, so let's go to another one quickly. Okay, so this case you could put it into a like a 4 kind of thing, any 4s, because here nothing lymph nodes, no calcifications, nothing, just one thing that is kind of new here in this breast. And I want you to see this because this is very, very important. So we do comparisons. This is the old one and this is the new one. And then this case, I'm going to go through it myself because it's 10 minutes left. So it's going to be a lot of, so this is new. This is new. So this is how, when we pick it up, we make these circles. We make these circles so that the technicians know what they have to do further. So I saw this mammogram and I said that we need to do spot compression views. And then we did, let me see, did I put up those? Okay, so then we spot compress them. And you see, it's still persisting. It's still persisting there. So this is the MLO. So it was still persisting. Then what we did is we did her ultrasound. Okay, ultrasound. We don't see nothing, absolutely nothing, no lymph nodes, nothing. But this abnormality was too big. Then what did we do? We could have done a stereo, but the patient said she didn't want a stereo. She wanted to do a biopsy. So then, an MRI. So then we did an MRI. And you're going to be surprised. Look at that. So that is the thing on T2. These are the subtracted images. And look at the kinematics. It's a very ugly mass there. So after we saw this, the radiologist said that, no, I'm going to do an ultrasound again. So then she went and she did another ultrasound, but then she didn't see any mass. Then we tried to do her under stereo. So when you see on a mammogram an asymmetry for which you don't see any ultrasound abnormality, you can do her under stereo because you can see it on both views. But her stereo also failed because there were vessels in the way. So we couldn't do the stereotactic biopsy. Then what we did is that we took her, under MRI biopsy. So I did this biopsy. You can see that I'm right in it. You can see that this is an MRI biopsy. Did an MRI biopsy for her. And this was, of course, cancer. So which cancers are sonographically occult is an important question for you. Who can answer? This is the post biopsy. So which cancers are sonographically occult? You don't see them on ultrasound. Anybody knows?
Ma'am, the answers are lobular, DCIS.
Invasive lobular. So we couldn't see any abnormality in ultrasound, tried twice, but that doesn't mean you should let the patient go. When there's a new abnormality, you have to investigate, okay? So do you guys know something about stereotactic biopsy? What does it mean? What is a stereotactic biopsy?
Ma'am, the answers are no.
Okay, so this is her here for a stereotactic biopsy. You can see this here. We positioned her, but you can see the vessels everywhere. There were vessels, so we could not do it. So in stereotactic biopsy, stereotaxis is a specific machine. It's done under mammo. So because we saw this, that you can only do it for microcalcifications, asymmetries, or something that you can see on the mammogram. So we see this on the mammogram. We don't see anything on the ultrasound. So stereotactic biopsy is less invasive as compared to an MRI guided biopsy. Okay. Because for MRI guided biopsy, you have to reserve a slot of 2 hours, and there's so much something that it's difficult to do it. So we naturally, when we did her MR, we did her ultrasound, we did everything, we didn't see anything. So we then said that let's do a stereo biopsy. And this was again me. And then I had to give up. This is every time we positioned her, we see vessels on the way. So see, this is a big vessel. Can you see that? So if she had started to bleed, that would have been terrible. So then what option did we have? We decided to go under MRI, because in that you you compress the breast differently, and then we did it. So stereotactic biopsy is for microcalcifications, asymmetries, and architectural distortions. That is what it is for. Okay, so.
Okay, ma'am, there is another question that how can we differentiate between 4A, B, and C?
Okay, 4A is something that looks, I'm going to bring this case up quickly. I kept the speed really, like I tried my best, but the thing is, okay, so now what is this? This is ACR type B. So there is scattered fibroglandular tissue, ACR type B, high density lobulated lesion. This is present lower, I'm going to say, central and lower, and this is outer. So let's go to the 1 minute. Okay, this is the same. Okay, so then we said lower and outer. So at 8 o'clock, we see this. So now this is not a simple cyst, right? You can see that it's complicated cyst. There's internal content. So this one I would put into 4A or 4B, because it just might be a cyst with hemorrhage. So if fibroadenoma, when do you biopsy fibroadenomas? When they become palpable. So then we put fibroadenomas into 4A. Anything you want to biopsy has to go into 4A. Remember that, okay? So, sorry, into BI-RADS 4 category. So if you look at something, it's palpable and it is new, a patient comes, then you biopsy it, you know it's going to be a fibroadenoma, you put it into 4A. When you know it's going to be a cancer, put it into 4C or 5, okay? If you're not sure, like this one, I'm not that sure, is it going to be a cancer or is it not going to be? I could put it into A or B, it doesn't matter, but don't put it into C. This you would not put into C, okay? So then there's another one, just quickly see, another case I heard. I have to show you one very quickly. I'll show it and then we'll, I have it pulled up here. Okay, so what is this? Let me search for my other case till then. What is this? Anybody? This is neurofibrosis.
Okay, the next candidate is Dr. Sana. Please unmute yourself.
No, I think it's okay. Like I can just do it and do myself so that I can complete the cases. So this is neurofibromatosis. Any questions in this case?
Ma'am, we have some other questions.
Yeah, sure.
What is the difference between synchronous tumor and satellite nodules?
Okay, let me just go. I'm going to show you one more and then I'm going to take your questions. So this is kind of a last case. This is very important because last time there was an exam, I was asked lots of questions. And so, okay, so this is another case. And in this, what do you see? What's the density? Anybody? It's C, right? There's heterogeneous fibroglandular tissue. So ACR type C. And then what is the abnormality here? So we see something there. It's not in the field of view. And here, these are clearly abnormal, right? So then we did the ultrasound. So this is the left axillary lymph node. And then this is left axillary lymph node. And then there is right axillary lymph node. So lymph nodes are abnormal, nothing in the breast. So what do you do to these? You BI-RADS them. So we're going to say BI-RADS 4C to it at least, because bilateral lymph nodes are abnormal, okay? So we BI-RADS 4C them, and then what we did is we biopsied them. See. So they should be, okay. So then we biopsied them. That's the biopsy, right? We biopsied them and then they turned out to be, what is this diagnosis? Lymphoma, right? See all those lymph nodes? See all those? That's all lymph nodes. So this is lymphoma. Now what do you do to this? It's not a breast cancer. So now you remove that BI-RADS from there. So next time, so when I did the post biopsy read, I put it to BI-RADS 2. I said she has lymphoma and nothing in the breast. So then you bring it back. But if you see abnormal lymph nodes, you put it to BI-RADS 4C, you biopsy it, it comes as a breast cancer, then you put it to BI-RADS 6, biopsy proven cancer. Okay. So lymph nodes, for lymph nodes, this is how you do it. There were some questions regarding lymph nodes in the last group, I remember. They were confused what to BI-RADS them, okay? So what was the question? There was the question.
Ma'am, the questions are, what is the BI-RADS category for neurofibromatosis?
BI-RADS 2.
Okay, and the BI-RADS category for lymph nodes?
Lymph nodes, if they are benign, 2. And you should not put 2 to normal lymph nodes on mammogram. Those are always 1. So for lymph nodes, which you are going to put BI-RADS category 2 is the one like we biopsied and they were benign and they were lymphoma, but it is not related to breast. So we brought those to 2. So the ones you see on routine mammograms, do not label it to 2. Okay.
Okay. And ma'am, BI-RADS category for fibroadenomas, 2 or 3? Is
2 if it's 2. So if you're not sure, you want to follow up, then you put them into 3. So then when you put something into 3, you do a 6-month follow-up, 2 6-month follow-up, that would be 1 year. And then third follow-up is going to be at 1 year. So you complete a 2-year follow-up for fibroadenomas.
Okay. And what is the name?
If you biopsy the fibroadenoma, you bring them back to 2 then, because now you know it's a fibroadenoma, right?
Okay. The next question is, what is the wire name that is used to localize the lesion?
There are multiple wires, but the one we use is the Copans, K-O-P-A-N-S, Copans wire.
Okay. And ma'am, another question is, when to biopsy fibroadenoma?
Okay, so when a patient comes, she has a new lump in the breast. And then whenever a patient comes with a palpable abnormality, you have to biopsy it. Many times, it's fibroadenoma, we biopsy it. So why do you biopsy fibroadenoma? Because of phalloides tumor. So phalloides tumor are there's something that is called fibroepithelial tumor. There are 2 masses in this. One is fibroadenoma and the other is phalloides tumor. So phalloides tumor can be benign, it can be borderline, or it can be malignant. So whenever we get a phalloides tumor on histopathology, we remove them surgically, but we don't remove fibroadenomas. So we always say that this could be a fibroepithelial lesion. It corresponds to the palpable abnormality. We'll biopsy BI-RADS 4A, we biopsy, and then when the pathology comes, then we say, okay, this is a fibroadenoma, you degrade it to 2. If it comes as phalloides, then you say that surgical consult is initiated and then the surgeon will remove it.
Okay, ma'am. The other question is, what is the BI-RADS for large lymph nodes, 2 or 4?
Large, and when the lymph nodes are abnormal, it's 4.
Okay. Okay, ma'am. The other question is, what is the difference between synchronous tumor and satellite nodules?
So satellite nodule is a tumor that is with the existing cancer. So she has a cancer in the breast and they're small masses. Like we saw on that MRI, there was a small mass, right? With it. So that could be a satellite. It could be a second cancer, but it's not synchronous. Synchronous is when it is diagnosed within 6 months of the primary cancer. And then within 6 months, you remove one cancer. And after 6 months, within 6 months, you see another cancer. And metachronous is in which it is after more than 6 months, then it is metachronous, okay? Okay. Synchronous and metachronous is that, but like in that one, for satellites, they are usually small. They are surrounding the mass and there are multiple. So I did have an MRI in which there were multiple satellites, but I think we didn't get to that MRI.
Okay, ma'am. Another question is it necessary for malignant mass to have posterior acoustic shadowing on ultrasound?
No.
Okay. And phylloids is in BI-RADS 3 or 4A?
When a phalloides come, we leave it in 4. It is suspicious unless a biopsy proven. So then they say it's a phalloides. So then they say it's malignant. If they say malignant, you take it to 6. If they say it is borderline, then you have to leave it at 3 and you have to suggest a surgical consult that it could be benign, you don't know. But usually they don't say these things on the biopsy, they say these things on the surgery. So on the surgery, if it is benign, they'll say benign phylloides tumor, that is a 2, right? But it's gone, they remove it surgically. So you're not going to have a phylloides tumor follow-up at all. There's no question about that.
Okay, ma'am, another question is, what is the difference between residual tumor or the scar tissue or the recurrent tumor?
Okay. So scar tissue is something that you see very commonly. I showed you that case in which there was scar tissue. And in scar tissue, what there is that you see architectural distortion. If the patient is given radiation, you see skin thickening and edema. And when residual is when a mass is left behind, it could not be removed completely. Like, for example, if it is adherent to the chest wall and you can take it off completely, it is rare because usually they would remove the ribs also when that happens. So then that would be residual. But the other option of a residual is they did a lumpectomy and then the margins are positive. So then the patient has residual cancer. So there are 2 options for that. If it is only DCIS, they give radiation. And if the residual is an invasive cancer, then they go in and remove the breast. They do a total mastectomy. So that is residual. And then post-surgical changes is just there's architectural distortion. So then you can say that, like I showed you that scar, that is scar. If the scar shows convex margins, it changes. You're doing serial mammograms and you say that the scar is changing. There are new calcifications there. There's a mass. So that could be recurrence. That is what recurrence is.
Okay, ma'am. The other question is, what is the BI-RADS for intramammary lymph nodes?
Intramammary lymph nodes are usually benign. They look normal. So you see an intramammary lymph node on a mammogram, and then what do? You do an ultrasound for them. And if you see that they're normal, they're small, the cortex is not thickened, then it's benign BI-RADS 2.
Okay. Ma'am, one other question left, and that is, can we have non-mass enhancement without definite mass?
Yes.
On MRI or on memory?
All the time.
Okay.
So you see non-mass. So when there is asymmetric tissue in the breast, so sometimes when you do a mammogram, you see that in the upper outer quadrant of the breast, there's always more dense tissue. And then when you do MRI of these patients, you see that dense tissue enhances more than the rest of the breast. So we call that non-mass enhancement, and we say it is asymmetric. It is present in the lateral breast or in the upper outer breast, and it is likely due to dense glandular tissue, but there's no underlying mass or distortion or something like that.
Okay, ma'am, one of the candidate wants to confirm that the washout is for aggressive lesions.
The washout can be seen in many things. It's not a specific thing. Where we use the washout is sometimes we like something we're looking. So you know what mucinous cancers are, right? Mucinous cancer looks like a fibroadenoma. It is bright on T2. It is well circumscribed. And then fibroadenomas will never demonstrate washout. I haven't seen till now. Rare cases of maybe. But what happens is that how do you differentiate T2 mucinous cancers, which look like same bright on T2, and then they are going to be very well defined. And then, so because they're going to show washout. So that is how it is. But the washout is not always abnormal because intramammary lymph nodes also show washout. Remember that, but they are benign. So we use it, but it's not that it's, if you want to decide if something is abnormal or not, look at the T1. Always look at the T1. How does the mass look? Does it look irregular? Does it look speculated? Look for other signs. Is there a satellite disease? Is there DCIS adjacent to it like we saw? So you have to look for other signs also.
Okay, ma'am. Next question is, when to do CT scan for breast masses?
Never.
Okay.
So you have to do ultrasound, you have to do mammogram, you can do tomosynthesis. I didn't have any tomosynthesis image here, but you can do tomosynthesis in which you kind of go through a 2D and 3D. So you scroll through the images up and down, and then you see better depiction of the abnormalities. Anything overlapping, you can make out that it's breast tissue. So that is that you can use tomosynthesis. You can use contrast enhanced mammography to differentiate things, and you can do MRI, but you can't do CT of a breast. I haven't had an indication where I saw a CT of a breast.
Okay, next question is, madam, what is importance of cortical thickness of lymph node?
Cortical thickness normal is cutoff is 3 millimeters. So anything at 3 or more than 3, you have to measure the cortical thickness. Like I showed you in a case, we saw lymph nodes just a little while ago. Yeah, so you don't measure the hilum, you measure the cortical thickness, and anything 3 and above, you have to flag it. So nowadays, because of this vaccination, COVID vaccination, in females, the lymph nodes are enlarged. So you can't all biopsy all those. So what you say is that they could be reactive because of vaccination. You call them for a follow-up 8 to 12 weeks. If they enlarge or remain like the serial on the next follow-up, they enlarge, then you have to biopsy it, because it may not be because of COVID, but something else. So on the, when you do the, if you do the follow-up and they have come down, like they are normal now, then you disregard them.
Okay, ma'am, there's a question that shouldn't we go for CT for staging of breast cancers?
You do CT chest, abdomen, and pelvis for staging breast cancer, but you don't do for the breast. So of course you do staging, okay. Yeah, but you don't do it for the breast.
Okay, ma'am, thank you so much. I think all the queries have been answered.
Yeah.
And this was a wonderful session, and we all learned a lot from you, especially regarding breast lexicon, and we hope to have more sessions with you. These are very informative. Thank you so much.
Say